Good morning, everyone, and I'm delighted to welcome you to the fourth of our seminars launching the Salford's Human Movement and Rehabilitation Group. And the focus for the session today is on clinical demands in mobility and health. My name's Lawrence Kenny, and together with my co-chair Jennifer Andrews, we'll be introducing the speakers and managing the questions and answers. As was the case for our previous sessions, we invite the attendees to type questions and answers, questions in the Q&A box on the right of your screen during the speakers' talks, and then we can queue those up at the end. Okay, I'll move on now to introduce our keynote speaker. I'm delighted to introduce Professor Neil Reeves, who's Faculty Head of Research and Knowledge Exchange in the Faculty of Science and Engineering, just down the road at Manchester Metropolitan University. His focus is on biomechanics and engineering solutions with a specific focus on feet affected by diabetes. And Neil's an active collaborator with one of our long-standing colleagues here, Chris Nestor, and they co-lead a work stream within the Greater Manchester arm of the Cities Fighting Diabetes programme. This is an activity led by Health Innovation Manchester. And Neil and Chris are currently hard at it, writing a NHR programme grant to investigate the value of wearable pressure measurement and feedback technologies in alerting patients to the risk of a diabetic foot ulcer. So I'm very much looking forward to hearing a fellow engineer speak about these things, and I'll hand over to Neil. Thank you.
Thank you, and morning everyone. Thank you for the introduction and thank you for the invitation to speak today. Very pleased to speak here today. As mentioned, I know a number of colleagues at Salford and really enjoy the work that's done at Salford. So a pleasure to be here and speak at this conference. So I'm going to talk about diabetic neuropathy and the prevention of some complications that arise with diabetes and diabetic neuropathy. So I'm going to speak about three main areas really. So firstly, something about foot biomechanics, gait, and how this is altered in diabetic neuropathy. Secondly, to move on and talk about some technology for diabetic foot ulcer prevention and some recent work that we've done with this. And then finally, to talk about diabetic neuropathy and driving. So this may seem surprising, but actually driving is an important motor control and coordination task, and I'll say more about this later. So it's well known that in diabetes, gait is altered. So people with diabetes, and particularly those with diabetic neuropathy, walk more slowly, they have a shorter step length, and in general it's characterized that, or these people are characterized as having a cautious approach to gait really. So this is in relation to falls, so they're very cautious about falls, but this characterizes their gait. One of the striking features of their gait is that they develop lower joint moments, and I know that many of you will are from a biomechanics background and will know what joint moments are, obviously, which are rotational forces around the joints, but essentially this reflects their lower levels of strength. So if people walk more slowly, joint movements are lower, and therefore the demands, the muscular demands are also lower. So consistently, it's been shown that people with diabetic neuropathy walk more slowly and develop lower joint moments around their knee, ankle, and hip joints. One of the main reasons for this, as I mentioned, is muscle weakness and atrophy, and you can see in these figures here from studies some time ago and more recently that this is a result of atrophy, so muscular atrophy, but not just atrophy actually. So the muscles are not only smaller in diabetes, but also they're infiltrated by fat and connective tissue. So the area that you think is a muscle, not all of that area has contractile ability because it's infiltrated by this non-contractile material. Also, so diabetic neuropathy starts at the very end of the toes, for example, because it's length dependent as nerves are affected. And it has been thought that the distal muscles of the ankle and the foot are mainly affected in diabetic neuropathy. But we showed recently in a paper that you can see in that bottom right MRI figure that actually also the proximal muscles of the leg, so the quadriceps, the front thigh muscles, are really quite affected by diabetes as well, and atrophy. So these are some of the factors that are underlying some of the gait changes in diabetic neuropathy. So we did a study recently where we fixed the speed of walking. So as I say, people with diabetic neuropathy develop lower joint moments, and this is thought to be because they walk more slowly. So if you walk more slowly, the joint moments are lower and the demands are lower. But we fixed the speed of walking and looked at this across a range of walking speeds. So you can see from 0.6 here, which is very slow, to 1.6 meters per second, which is fairly quick, with somewhere in the middle, 1.2 meters, the average speed of walking. And we looked at this in controls, so people without diabetes, DM, so people with diabetes, and DPN, which is people with severe diabetic neuropathy. And independent of the speed that you look at, people with diabetic neuropathy develop significantly lower joint moments. So this is right across the different speeds. So significantly lower moments in people with diabetic neuropathy. So this showed actually that it's not only the fact that people walk more slowly, the reason why people with diabetic neuropathy develop lower joint moments, but independent of walking speed, they develop lower joint moments. So the question for us here was, well, how? So they're walking at the same speed as these other groups. How generate these lower joint moments? What's the mechanism? And this is around the ankle joint. So what we did is to look at the biomechanics around the ankle, and we could measure what we call an external leverage, which is the external moment arm that you see here. And this is this perpendicular distance between the ankle center and the ground reaction force. That's the external leverage. And then we also looked at the internal leverage, which is this perpendicular distance between the ankle center and the Achilles tendon, so the line in which the muscular force acts, essentially. So we can look at this external leverage, and we did look at this with gait analysis. And we looked at this internal leverage, this internal moment arm, using MR imaging. And this was during weight bearing, so weight bearing scanning to simulate what it's like during walking. So what we found is that actually the people with diabetic neuropathy had significantly smaller external moment arms. So this leverage, this external leverage around the ankle, was significantly smaller in people with diabetic neuropathy. So that the value, in terms of the values you see in the table, it seems relatively small, but this can have a meaningful impact upon the moments. So because this external leverage was smaller in people with diabetic neuropathy, it increases something called the effective mechanical advantage. And this is just the ratio between this external leverage that you see here on this picture and this internal leverage, so between the ankle center and the Achilles tendon moment arm. So the main message really is that by increasing this effective mechanical advantage, the people with diabetic neuropathy can minimize the ankle plantar flexion forces. So in terms of a strategy, a natural strategy, this is quite a good strategy that enables them to minimize the plantar flexion forces that they're generating during gait, because as I've mentioned already, the people with diabetic neuropathy are much weaker and have lower muscle mass. So this is a quite intuitive and a strategy that makes sense, really. So moving on to the second area, really, of diabetic foot ulceration. So diabetic foot ulcers are essentially a wound on the skin that typically develops on the bottom of the foot. And one of the main reasons why people have problems with these diabetic foot ulcers is because of diabetic neuropathy. So they lose the sensation, they lose the sensory perception in their feet, they lose the gift of pain, and which seems like a strange thing to say, but actually, if you can detect pain, then you can take action to do something about it. Where if you lose that, you're not able to self-adjust. So diabetic foot ulcers are a real health and economic burden for society, for the people who suffer them as well. And diabetic neuropathy is one of the main risk factors. Now, 1 in every 3 people with diabetes will develop a foot ulcer at some point in their life. And those who do have a foot ulcer have a very high chance of going on to get another one. So the recurrence rates are about 40% within a year, rising to 65% within 5 years. Also, the likelihood is that these ulcers, if they go undetected, can become infected. And that means they might progress on to requiring some form of amputation. So you can see really from what I've said that diabetic peripheral neuropathy, this inability to self-regulate really, lends itself to technical solutions to be able to help in the management of diabetic neuropathy and also prevention. And so that's part of what I'll talk about now. So as many of you will know very well, and you'll do at Salford, we can measure foot pressures, and we have been able to for many years, but we typically do this in the lab. And these are lab-based systems which are typically tethered to cables, and we're typically limited to the distance that we can walk and move and measure foot pressures in. So this project is really about measuring these foot pressures outside of the lab as part of the daily environment and as part of the daily routine. And what we know about foot pressures in people with diabetes and diabetic neuropathy so far is really just based upon lab studies. So we could say that really it's just a snapshot of what people are doing as part of their whole daily routine. And we could also ask, is only walking important in the risk of someone ulcerating? There's this study, for example, by Bijan Najafi showed that may not be the case, because they tracked the activity of people with diabetes, and they showed that actually people with diabetes and diabetic neuropathy spend almost 3 times as long standing on a daily basis as they do walking. So 3 times as long standing as they do walking, which shows that actually, although walking will almost certainly be important, the time spent standing, for example, might be an important risk factor in people developing diabetic foot ulcers. But we know nothing about this really, because we haven't been able to measure it. And also we haven't been able to measure the activity of what people do when they go outside the lab and they load their feet as part of the daily routine. So as I mentioned, there is good evidence to show that high foot pressures are linked to the development of diabetic neuropathy. But all of this is based really upon lab studies. Again, from lab studies, we do know the concept of pressure feedback seems to work, albeit in a limited lab environment. And that led to this study really, where we were trying to take these measures outside of the lab in the real world to measure pressure and to feed it back through a novel device, to see if we could reduce the recurrence of foot ulcers in patients who are very high risk for developing foot ulcers. we published this work, actually, this proof concept clinical trial last year in the Lancet Digital Health. So I'll just talk through a bit of this, some of the outcomes. So the main thing to take here really is that these people, none of them had active foot ulcers at the time of coming into the study, but they all had a previous history of foot ulcers. So that meant they were very high risk for developing another one. So as I mentioned before, a roughly 40% chance of reoccurring, having that foot ulcer reoccur within 1 year, or even up to 60% over 5 years, 65%. So this is the device that we used for the study, and this was a randomized single-blind control trial with 18-month follow-up, with the endpoint being someone developing a diabetic foot ulcer, or the end of follow-up. So the device that was used as part of the study, and as it was used as it was at the time, consisted of this thin insole sensor that goes into the shoe with a pod that connects to the top of the shoe, and this measured and relayed pressure information to a smartwatch that was worn by the participant. And you can see what the participants saw on the face of this, the image of this smartwatch here. So essentially, this was measuring and feeding back pressure information to the patient on a continuously while they're wearing it on a daily basis. And people were seen in the clinic every month to check the feet and also recalibrate this device. So as it was used at the time, it had 8 sensors in these locations, but for simplicity to the participant, it just showed us 4 regions. And if the pressure was high on any region, it would indicate that and tell them where the pressure was high. And they then had a series of 3 simple steps that they were told to use to offload this high pressure. So we consented 90 patients to this study. They began and had a wearing in period, a 2-week wearing in period with the technology before they were randomized. At this point, we had quite a large dropout actually, which was likely partly due to using the technology. And we could talk a lot more about just that point actually. But after that, they were randomized to intervention and control groups and included in the intention to treat analysis. So what we found in terms of the primary outcome measure, in the control group, we had 10 ulcers from over 8,000 person days. In the intervention group, we had 4 ulcers from just under 12,000 person days. And using a Poisson regression analysis, we found a significant 71% reduction in the risk of reulceration in the intervention group compared to the control group. Now, what we also did was to look at which patients were the best compliers, if you like, so used the technology the most. And we could measure this from the pressure information that we were getting back from the device. So we were able to measure and record this pressure information and store it on the watch and download it at the clinic visits. So looking at these best compliers and reanalyzing the data, what we found was that in the control group, there was 10 ulcers from over 6,000 person days, and then in the intervention group, 2 ulcers from over 9,000 person days. So this readjustment for the good compliers led to a further an 86% reduction, which was improved from the first analysis in the risk of reulceration in the intervention group. So 86% compared to 71% reduction for the overall analysis. Improvement when we take into account good compliers. So this shows survival curves and the Kaplan-Meier time to ulcer estimates for this compliance adjusted analysis, with the red curve showing the intervention group and the control curve shown by the green line. And you can see that they start to deviate about 200 days, but didn't quite reach significance on the Lagrange test. So what this work shows really is a proof of concept that measuring and feeding back pressure to the patient improves their ability to self-regulate. It empowers them, and with this information that they wouldn't otherwise have because of peripheral neuropathy, and it shows some efficacy for reducing the incidence of diabetic fall. So just to by mentioning some work on driving and diabetic neuropathy. So this came about because we did a series of studies looking at gait in people with diabetic neuropathy, and we did some tasks where we used eye tracking to measure visual gaze during movement and to see how this guided movement. And basically from that we found that people with diabetes and neuropathy used their vision differently, so their visual gaze behavior was different. They were slower to look between targets, stepping targets, which meant they had poorer stepping accuracy. So working with Dilwyn Marple-Hubbard, who has worked on driving for many years, we know that poor eye movements essentially translate to poor driving. And so we were interested to look at driving for this reason, and also for the fact that we know that proprioception is affected at the ankle, and obviously driving is something which involves very fine control of the ankle for accelerator pedal control. So we looked at eye gaze and how this affected driving, but we also looked at control of the accelerator pedal. So that's what I'll just briefly talk about now. So we measured proprioception on a dynamometer and indeed found that proprioception, as expected, is worse in people with diabetic neuropathy. So you see that on the left here. So a higher bar, greater error in ankle repositioning, so poorer proprioception. The middle figure shows driving speed on the simulator, and we had two drives, so two drives of this course, which is the black and the open bars. And basically people with diabetic neuropathy drove more slowly. Now, despite driving more slowly around this course on the simulator, they had a higher number of loss of control events shown by this curve on the right. It did drastically reduce from drive 1 to drive 2, as you can see, but nevertheless they had a higher loss of control events. So we can measure this from the signal of the steering wheel. Now, I don't show the detailed results of it here, but the reason for this was because we were able to measure the degree of compression of the accelerator pedal. And basically what people with diabetic neuropathy do, in contrast to healthy controls and people with diabetes without neuropathy, they tend to either compress the accelerator pedal completely like this, if you can see my hand, or they have it all the way up, whereas other people tend to use much more accelerator pedal. So if you can imagine, they regulate their speed by pressing the accelerator all the way down and releasing it all the way in. This leads to more loss. So to finish, I've shown you something about altered ankle biomechanics during walking in diabetic neuropathy. I've mentioned something about how we might be able to reduce diabetic foot ulcer risk using some novel pressure feedback technology, and just briefly told you something about driving and how this might be affected by diabetic neuropathy. But the other thing to say about that as well is that it does show the potential for training. So there was an improvement from drive 1 to drive 2, and potentially for technology that might be able to help these people be safer during driving. So thank you very much, and I'm happy to discuss and take any questions. Thank you.
Thank you, Neil. That was a very interesting presentation, and I think reflects the move in the community away from just studying in gait labs to thinking more carefully and using the technology that's around to study what's going on in the real world. And I think that's really excellent way forward. We've got a question from one of the audience members here. So I'll read it to you. How did people behave when they received feedback? Did they alter their gait or offload by reducing walking and standing time? And was there a difference in stepping standing time between the two groups?
Yeah, so this is in the study where we measured pressure to reduce diabetic foot ulceration. Yeah, that's a good question. And the short answer is that I can't answer that just at the moment, but the more detailed answer is we measured pressure information in everyone over 18-month follow-up. That was part of subsequent studies, which we are now getting the data on. So we're starting to be able to understand that and hope to be able to release that soon. But just very briefly, we did have anecdotal reports on what generated the pressure alerts, and actually it was quite often it was standing or even sometimes driving by having the heel in contact with the floor. So yeah, so hopefully we'll be able to answer that more comprehensively over the coming months and year.
Great, yeah, thanks. So one more question from one of the audience members. Are there any driving restrictions for people with neuropathy? And if not, do you think there should be, or should there be additional training for these people to avoid loss of control? And speaking as a cyclist, that's a question close to my heart.
Yeah, it's a very good question, and it's a very sensitive area, really. And I at the moment there are not. So my colleague Dylan Marple-Hobbit is really taking this area forwards, and he's been working with government actually on this as well as the driving work that he was doing before. There are adjustments that people can make already, and one of the study participants from this work had accelerator paddles on the steering wheel. So she used the steering wheel to accelerate rather than the foot pedal. So there are adjustments that can be made. Knowing what we know, there are other sort of technical adjustments that might be made to the car in terms of damping the accelerator pedal, or so that there's a lot that can be done. But at the moment, I don't think there is anything that is done, and we don't think, so we've spoken to the DVLA about this as well, and diabetic neuropathy is not one of the things that is currently excluding people from driving.
Interesting. Okay, I think we're running a bit short of time now, but so I think we'll wrap up there. And thank you once again, Neil, for an excellent talk. That was really very insightful. Thank you.